Good afternoon, everybody. My name is Magda Hegeman-Apel, and I'm the Vice President of Education and Training at Meals on Wheels America. In that capacity, I also develop educational courses for the National Research Center on Nutrition and Aging, which we host with a grant from the Administration for Community Living. And it's the National Research Center on Nutrition and Aging that brings you this webinar. We are delighted to see that we have so many attendees here who want to learn how your RD can help you with the value proposition that our programs can have for healthcare payers, and how they can enable you to increase your organization's engagement in the healthcare arena. We have Susan Seville-Schreier as the main speaker with us today to talk about the topic, and it's going to be very interesting. I've seen the slides. And then we have Holly Kellner-Grueling from the Administration for Community Living. Holly, as you all know, is the National Nutritionist for the Administration on Aging at the Department of Health and Human Services within the Administration for Community Living. She's been in that position since August 2012. Holly's an RD herself, and she worked for more than a decade as a Florida State Unit on Aging Nutritionist for Older Americans Act programs. I have a couple of housekeeping notes for you. Your lines are muted, but you'll understand because we have so many people on the webinar. But we do encourage you to interact with us. There's going to be a couple of questions that Susan has for you. So use the function in the little menu that Hannah is showing you, where you have a box for questions. Type your question in and send it to the whole audience, to all participants, and I'll be monitoring the questions together with Linda Netherville, my colleague at Meals on Wheels, and we'll ask them of Susan when there are good moments to interrupt or to stop her presentation. And with that, I'm passing the mic on to Holly, who will introduce our speaker of today for you. Holly?
Thank you, Magda. This is Holly Grueling, and I just wanted to take a minute to set the stage for Susan's presentation. As we all know, in 2012, ACL was created around the fundamental principle that all people, regardless of age or disability, should be able to live where they choose, with the people they choose, and be able to fully participate in the communities. In the U.S., currently, there are 65 million people aged 60 and older. All but a tiny percentage of them live in non-institutional settings, as do nearly 57 million people with disabilities. Both populations are growing, and older Americans are the fastest growing demographic in the country. And in 3 short years, by 2020, there will be more than 77 million people over the age of 60. Bringing together, ACL has been bringing together aging and disability work, and it's worked tremendously well. There are many similarities in the services and supports older adults and people with disabilities need in order to live independently. And agencies are leveraging learning and best practices to meet the needs of both groups, the similar needs of both groups. As our collective network continues to expand its footprint within the home and community-based arena, it's important to take stock of our network's strengths and to continue to promote and leverage those strengths to support the individual's ability to continue to live in the community. Our next speaker is providing information on how our networks can maximize one of its unique strengths, our network's dietitians. Our dietitians are very familiar with age-related nutritional and physical deficits that often occur with aging. This could be expanded to the disability network too, but I'll hold off on talking about that right now. Our nutritionists are very skilled in working and understanding older individuals. However, in most areas of the country, our network of professional dietitians rarely enter the home. Moreover, we know that some information can only be obtained by getting into the home. But it's important to note that an RD can't just know how to get in the home, but they have to be effective once they're in the home. It takes skill and finesse to get true information without being threatening. Susan will talk about that in her presentation. I know many of you are waiting to hear how this will be paid for. How can your network pay for an RD to complete a nutritional assessment within the home? And I'm sorry to say I don't have a magic bullet or a magic funding stream for you. We are working on this collectively together. However, I do have a few ideas that I want to share with you all in hopes that collectively we can start thinking how we can move our network. First, there are many networks here and there that are already having the RDs go into the home. For example, in the state of Rhode Island, eligible home-delivered meal participants must have a dietitian visit them in their home first before the home-delivered meal is approved for participation. The RD has a unique perspective on the mechanics, needs, and abilities of food intake, and is uniquely positioned in your network to help improve the nutritional status of your community's older adults. Did you know that 1 out of 2 older adults are malnourished? And in fact, approximately 30% of older people admitted to the hospital arrive malnourished. And of course, being malnourished while in the hospital generates an increased length of stay. Another example of how it works already is in Tarrant County, Texas. Sherry Simon is the dietitian out there. She's been working with local hospitals and researchers for several years now. She has proven to her local hospitals that her team of 6 dietitians is worth their price. She has proven the nutritional interventions are effective at decreasing hospital stays, emergency room stays, and obviously healthcare costs. I would love to hear how others have had successful models in this area. Research indicates that malnutrition or poor nutrition has detrimental effects on an older person's health. In addition, if an older person is malnourished and then has an acute illness, they're more likely to enter the hospital. Moreover, if a person is malnourished upon discharge, the rate of readmission is higher. That information is very important to the bean counters or those that are trying to decrease healthcare costs. You in the community should be able to recite this information and then offer solutions. Having your RD in the patient's home might be just the ticket. As I said in the beginning, our older population is growing and currently federal dollars aren't keeping up. We need you to think outside the box. What can you do with the staff you have? Can you use them to generate income for your agency to perhaps help decrease waiting lists? We are asking you to consider how your consultant or full-time RD could benefit your bottom dollar by helping your program generate income for your program. One way is for you to learn about what the RD can do for your older folks and then share that with your local hospitals or your local primary care. Another way is to find out how many malnourished individuals are being discharged from your hospitals. CMS has all this information, and you can find it. We just need to expand where we're going. So with that, I am so very pleased to introduce our next speaker, Susan Schaffel-Schreier. She is a certified gerontologist and is a professor in the Department of Family and Preventative Medicine, Division of Family Medicine, University of Utah School of Medicine in Salt Lake City, Utah. She is an adjunct professor in the Division of Nutrition at the University of Utah. Currently, she is the Director of Geriatric Education in the Family Medicine Residency Program, where she oversees interpersonal teams that care for older adults across the continuum of care. She provides both gerontology and nutrition expertise in multiple clinical settings. She's an active member of the Academy of Nutrition and Dietetics, the Society of Teachers of Family Medicine, and the Utah Aging Alliance. She is the past chair of Healthy Aging, DPG, and past president of the Utah Academy of Nutrition and Utah Nutrition Council and Utah Aging Alliance. She has received numerous clinical and teaching awards. Recently, some of her accomplishments include co-authoring 3 peer-reviewed guidelines for the Agency for Healthcare Research and Quality. She's wrote a chapter in the book titled Nutrition for the Older Adult, and her recent publications and presentations include discussing malnutrition, services for older adults, weight management, and interprofessional geriatric clinical education. And with that, Susan, if you want to take over.
Thank you, Holly. It's wonderful to be with all of you, and I'm excited that we have so many participants that are interested in reaching out and working with older adults in different settings. And today we're going to talk about home visits. And so next slide, please. Great. I put this one in because I think we need to validate ourselves. I'm just going to read it. Home visits are real-time assessments that provide the most accurate nutrition information. You know, we think about being in the hospital and having all these magnificent technological tools at your fingertips, and you assume that that's where the accurate information is going to come from. But in reality, you know, nutrition, and I'm preaching to the choir, I'm sure, but, you know, there's more to nutrition than labs or, you know, skin fold assessments or whatever. And you need to look at the biopsychosocial components. And by going into the home, you know, it's the perfect environment to really bring clarity to nutritional issues. And these are very important with older adults. I always think about it as the 5,000-piece puzzle, and with a picture of a wave on the ocean. And, you know, you're going into the home and you're going to try and put these pieces together. All right, next slide. Another, just a couple of points before we get into the actual home visit process, and why home visits work. I'm using the story of the blind men and the elephant. And if you recall, there are these blind men that are provided access to certain anatomical parts of the elephant, and they need to determine what it is and, you know, the what, where, or why of it all. And of course, each one comes to a different conclusion. And that's what's happening, I feel, in healthcare, health services. We live in silos, and we're not communicating, and we don't see the whole picture. One way that we can see the whole picture is going into the home. And so the home visit is extremely important. Next slide. So another just thought on why home visits work. And this is a question that's been put out there in both healthcare and health services. And I've altered it a little bit to address what we're talking about today. But basically, is it sufficient to address older adults' health and nutrition without changing the conditions that made them unhealthy in the first place? And what this is all about is a concept called social determinants of health, and understanding that there's more to your health than your blood pressure or the medications you take. You know, it's the total package. It's population health. That's where we're moving in healthcare delivery. You know, maybe it's the ACA or whatever we're going to call it in the future, but actually there's a lot of institutions that are moving forward with this already. So just let's take a peek at the social determinants of health. And I just want to point out that healthcare is only 20% of what's determining a person's health. And look at the other percentages. Just to note, socioeconomic factors, 40%. So again, we actually have to put the total picture together, and we have to communicate to make the health of our older adults improve and prevent them from being hospitalized and or having to leave their home. Okay, next slide, please. We're ready to move into the process. Let me just tell you that I've been doing home visits for many decades, and in a variety of different what should I say, focuses. Right now, my focus is educating interprofessional teams. So I have graduate nutrition students, pharmacists, I have family medicine physicians, and PAs, anyway, and we go out and we do home visits. We also we're doing home visits for the educational side of it, but it's also in conjunction with our clinics, our outpatient clinics, because we are now assessing risk of these patients, particularly towards hospitalization. And so when we get together and discuss these patients, if we can't put the pieces of the puzzle together, the only way that we know how to do that is to go out and do a home visit. And it works like a champ. Anyway, so that's where I'm coming from right now. So here are the steps that I follow. Hopefully they'll ring true to you, or maybe you'll pick up some pearls that you can apply as you develop your own thoughts and process. So the call, actually the most important part almost, because if the older adult does not want, does not receive you well, then you're not going to have a home visit, are you? So you call, obviously greetings and introductions, but there's two things that I've learned that I have to state right up front with the older adult. Otherwise the phone's going to click. I need to tell them that we are wanting to come out, and our intent is to help them stay in their home. Now, I put a sentence here as an example. You might want to create something, but, I'd script it because, and just say it first and foremost, and then the second thing they want to know is cost. And so make sure that that's fully understood. And then if the cost is low and, you're telling them that you are wanting to help them stay in their home, they're just going to relax, and they're going to go, oh, sure, come on out. And then you've got almost your foot in the door. One last thing to think about is when you do set up the time, think about who should be present. Family members, anyone with home health, personal care aides, friends, neighbors, have that discussion with the client, the older adult, to see what they have to say. Okay, next slide, please. Okay, so we've got an appointment, hooray. And so now we need to prepare. And I think probably the best way to prepare is to think about observing, assessing the patient's functionality. Functionality is a wonderful tool that crosses all disciplines, and that you can assess them and have some concrete information. But most importantly, again, it's observation and performance-based activities, and that's what we're talking about with functional assessment. And then make sure it's a conversation. Yes-no questions don't work. You might have a yes-no on your assessment intake form, but just try and make it a conversation. And then, oh yes, and remember that you are a visitor in that person's home. So they're driving, you're not, and so you have to be aware of that and listen to what the older adult is telling you. So what the functional assessment that I like to use most in home visits are the IADLs. That stands for Instrumental Activities of Daily Living. And it determines the ability of someone to interact with their environment. Usually folks that have ADL, those are the very basic deficits, they probably have a lot of help in their home, or they've moved on to assisted living or higher level of care. So most of the time it's a good starting point to look at IADLs. There are a variety of different tools out there, and then there's also a variety of the things that you're assessing or how they state them. I'm using a tool that has 8 categories in the IADLs, and they include meal preparation, mode of transportation, laundry, ability to use the telephone, shopping, I put in parentheses, food, housekeeping, responsibility for own medication, and ability to handle finance. I think as you look at that, you go, oh yeah, I can see a nutrition component there. Obviously food preparation, how do I get to the grocery store? How do I, can I get around the grocery store? But, also the idea of calling to place an order for groceries, or handle your finances so you can, afford the groceries that you need. And then all those other associated types of activity, like housekeeping, reflecting cleanliness and medication compliance or adherence and that type of thing. So anyway, starting out with conversation and observations to look at the IADLs is really a great idea. So I'd like to tease this out just a little bit more to give you an idea of what you're going to be looking for, what are you going to be observing. Not to spend a lot of time, but I want to introduce you that these are not yes/no questions, and there's a gradation. Next slide, please. Okay, so here's two of 8 functional tools. One is laundry, and at the very highest level, it does laundry completely by themselves, and at the most dependent must be done by others. And the mode of transportation, again, the most independent, travels by themselves, arranges, and and then down to does not travel at all. Again, the gradation is the important part. Medications follow the same suit. Able to do it all on their own, not capable of doing it at all.
Susan, it's Martha, can I just interrupt you? We're actually on a different slide. We're talking about the use of the telephone and shopping. Hannah, can you adjust the slides, please?
Oh, I'm so sorry. Yes,
no,
yes.
Okay.
Thank
Don't
you.
worry.
Yeah, I flipped too soon. Yes. Okay. Right. Well, again, it's still the same type of feel. You can use the telephone, you can't use the telephone, and then there's everything in between. And then there's the shopping. Again, taking care of your needs independently or completely unable. And the way you're going to tease these out is through conversation. Asking the question is really not going to be as helpful as you might think. So, okay, we've gotten past the shopping and the telephone. Could you go to the next slide, please? Okay, so here's food preparation. Again, the gradation, but I love to ask this question to my, particularly my medical students. Can you plan, prepare, and serve adequate meals independently? Most of them can't. And so, it's good to find out what their history. The point is, have they done this in the past? Were at one time were they able to do these things, or is it a lifelong situation? Like traditionally, older gentlemen were not too active in the kitchen, type of thing. And housekeeping. I don't think we need to go over these a lot, but I just want you to have these so that you can have them in your back pocket, so that when you are asking, you can kind of say, oh yeah, really independent or really dependent or somewhere in between. So let's move to the next slide. And there's the laundry, which I think I already mentioned, and the mode of transportation. Let's go to the next slide, please. And okay, responsibility for own medications. Drug-nutrient interactions are huge, and if there's an issue with taking their own medications, then more than likely the older adult could be at nutritional risk. And it's also a great sign of maybe some cognitive decline. Along those lines with cognitive decline, I love when I'm asking them about their food preparation. I ask them about, what do they like to prepare and when did they prepare it last. I think I talk about that a little bit more in the next couple slides, so I'll leave that alone for right now. And then the finances. So again, keep these in your back pocket, be thinking about them, and have them guide you as you are assessing the older adult as you go through their home. Okay, let's go to the next slide. Okay, so we've made it to the front door. Hooray. Make sure, again, you've got your name tag on, you've introduced yourself, and refresh the client's memory. Many times, there might be a memory issue, or they just had a real busy day, or they're not feeling well, and just give them that benefit of the doubt, and just add it into your introduction at the door, and then hopefully they'll welcome you with full open arms, and you're on your way. Okay, next slide. All right, I always call it making my way to the couch. That's a very important step, and it's not that you're welcome in the whole house, but you've made it in, and there's they might still be a little leery of what this is all about, so you need to be reinforcing that you're wanting them to stay in their home if they wish, and maybe the cost thing if that's an issue. When you're walking in, again, this is observation. Look for signs that give you an idea of how well they're doing in their home. As you're first entering, ask about or say something. Wow, it's so easy to park, and that actually might take you to driving and driving safety, or ability to to transport themselves to the grocery store, or the lovely yard. Are they out in their yard working? Are they physically active? Looking at family photos. Many older adults have a lot of photos up of their family, and look at those and kind of get a weight history from that. And if you're not sure if that picture is the older person you're looking at, then just say how beautiful they are, and is that you, or something like that. Anyway, but they'll be forthright to tell you and be very proud of it. Other observations: look for the client's clothing and hygiene. Ill-fitting clothes, soiling, meaning food, urine, feces, and clothing pairing. Is it really off? And that could potentially be indicative of a cognitive deficit. So I just listed a bunch of indicators at the bottom of this slide that what we've done so far, could be a sign of some issues that need to be addressed. We mentioned memory, incontinence, poor fluid intake, the loss of weight or gain, the driving, overall safety, social support. So you can see a lot before, just on your way to the couch and when you're sitting on the couch. Okay, next slide. Okay, so long last we're on the couch. And this is a chit-chat time, but it still can bring, bring up a lot of great information, asking how long the client has lived in this particular neighborhood or setting. So what you're trying to find out about are adjustments to the living situation, if it's changed recently, interaction with neighbors and family, or is there family living in the area? And then again, they'll have a story or two to tell, and it's a get to know you, but also very enlightening. And then as that goes well, then when the time is right, you can ask if you can see how the client gets around their home. And that's how I state it. I try to stay away from, I'm going to assess your nutrition, or I want to see the food in your kitchen, or whatever. I just, it's a home assessment. Let's see how you're doing. So the key areas that we want to be looking at are the kitchen, of course, and then bath and bedroom can be informative as well. Next slide, please. Okay, so with that, I've kind of given you the beginning phases of this home visit process, and I just thought maybe we'd take a break and see if there are any thoughts or comments about this process.
Yeah, absolutely, Susan. This is Magda. I would like to ask people to put questions or comments they have in the questions box while I ask the ones that came in of Susan already. There's a little bit of confusion between IADLs and ADLs. Could you please explain that a little bit more?
ADLs are considered basic activities of daily living. They are the activities that you do on your own mainly. Dressing, bathing, toileting, transferring, that feeding. So again, very basic. Instrumental activities of daily living. Those are activities that require you to interact with your environment, meaning physical or social or whatever. So it's a higher level of functioning. I hope that helps.
Okay, that does help. And then there was another question about, are we sending the slides around? And the answer is yes, you'll get a copy of the slide deck tomorrow. But then there's a comment for you. One is that Meals on Wheels RDs need to make sure that their local dietetics educators are training the new generation of RDNs to be able to make home visits. It's not easy to find RDs that want to do this kind of work. Most of the RDs that work here have now been former interns of ours. So that's an interesting point. Is that something that you've encountered, Susan?
You know, when the dietetic students rotate with me and I give them a rundown of the different things that we do, they love the home visits. And I would say actually most of the different professional groups, disciplines, they love the home visit, and they're wondering, how can I incorporate this into my future position, maybe with a home health agency. You know, it's not a given that dietitians are involved in, you know, home health care, but it's increasing. And then, of course, with aging services, the aging services here in the state of Utah, there have been, I know, where dietitians have gone out and done home visits. I don't know if I answered that question as fully as she wanted.
Okay.
Is
well,
there
there's a number of other ones, so
okay.
if you won't mind.
Yeah.
I would
okay.
like, the question is the assessment that you described evidence-based? And if it is, what's the name of the assessment tool?
The IADLs, they are well studied, and so there are multiple ways, multiple tools that you can use. I gave you one example. I'll take it to a step further. When we look at the comprehensiveness of what we're talking about, I'll call it a comprehensive geriatric assessment more formally. The comprehensive assessments have been studied, and they find that they reduce hospitalizations, healthcare costs, improve independence. So there's a body of literature out there. With home visits themselves, probably not as much, but the concept of the whole person in care of the older adult is definitely there.
Susan?
And maybe afterwards you can share that with us, and we can communicate that with the attendees. Sorry, Holly, go ahead.
No, I just wanted to say, this is Holly Grueling. You know, with the Older Americans Act, we often have our home-delivered meal recipients with 3+ ADLs. So they are still living in the home. But what you're talking about is finding a new venue for the RDs on the home front to coordinate with their local healthcare entities in order to make money for the agency. And so this is a different group of people. This is not necessarily those that are already in the Older Americans Act programming. So I just wanted to just clarify that. That's why people are throwing out ADLs, and you're talking about IADLs.
Oh, I see. Yes. I just thought I'd start with the broadest sense. It's not that we don't start assessing ADLs. It's not uncommon, just because of time, and I just thought the IADLs would be the better route. But I can see what you're saying. Yeah.
Okay, and that's very helpful, Holly. Thank you. And there's another question comes from a state unit on aging. Can you address the policy regarding personal safety when you're visiting clients in their home?
Well, you know, again, I work for a university, and I'm not with an aging unit, but there will have to be liability insurance. There'll have to be some coverage that will have to be created, I would assume, just as I am covered by my own insurance as a university employee and provider of health care. So that's I don't know if, Holly, you would feel better in answering that.
No, I was just going to say that most RDs do have liability insurance. And this is obviously one of the things that agencies would have to think about and figure out before they move their employees into a client's home or a potential client's home. So this is just one more thing that would have to happen. And dietitians generally have liability insurance, just professional liability insurance.
Oh, yes. Your place of employment might not pick that up. You might be paying for that out of pocket. It varies, yeah. But in my case, the institution picks up my cost. Okay. Any other questions?
There's a number of other questions, but I think knowing what you still have to communicate to people on the phone, let's get through that, and then we can get to these remarks and questions a little bit later.
All right. Very good. Thanks. All right. Well, then to the next slide. Okay. We're in the kitchen, an important spot. So you've asked for approval for the older adult to show you around their home, and you want them to show you their kitchen. And again, this is conversation. Ask about the food choices and preparation. Ask about what appliances they like to use most. And something that I do with all home visits is I ask the older adult to reach up as high as they can and to grab something out of the cupboard, and then I also ask them to open the drawer at the bottom of the refrigerator. This is not only to look at flexibility, maneuverability, but it's also a way for me to see what's in their cupboard and what's in the refrigerator without having to actually ask. And it always seems to work like a champ. Asking about the favorite meal to prepare, and more importantly, when did you prepare it last? Because sometimes it's been a long time, and so that's indicative of a change. And then possibly, where do you shop? Okay, next slide, please. Okay, we're still in the kitchen. So what you see is what you get. And so, check it out. Look for the overall cleanliness, dirty dishes and appliances. Is there soap available? We talked about the maneuverability, physical abilities of the older adult. Are there signs that there are pets? And pets can be kind of a love-hate. I adore them because they bring such joy to older adults, but on the same hand, they do take a lot of work, and the older adult has to have the energy and the abilities to do that. And then there's always the issue of, are they prioritizing cat food over their own, purchasing cat food over their own food? I think that's kind of the classic. I don't really see it too much with dogs, but cat food a lot. And then lastly, looking at the kitchen and dining table. And I do want to just stop here and just give you, I've got so many stories about home visits, but I think this one will bring home a lot of different points that we've been talking about. I was working with an older woman. She had iron deficiency anemia, and she was losing weight. And I'd seen her in my outpatient clinic several times, and nothing, I just wasn't connecting the dots. So we went out to do a home visit. And in conversation in the kitchen, I make note of the dining table and how lovely the placemats were, or whatever. I don't totally recall now. But the older adult readily provided the information that she does not eat with her son. She's living with her son. She does not eat with her son because her son will not let her eat until he is full. So she was losing weight because there wasn't enough food, and that, he was first choice. And so, there's a sign of abuse. And you just can't pick that up too well in an outpatient clinic and the like, but when you're in the home and you're in conversation. So all the different aspects of abuse come up. And I just thought that was an important story to be told. Okay, next slide, please. Okay, so now, instead of me telling you what the nutrition risk factors are, I was thinking that maybe you could provide us with some thoughts. Think about what we're looking for. I've talked to you about different areas and potential things to look for and what they indicate. But let's put that back out to the audience and see what other points they might have.
Right, and while you're all filling in your remarks on this question that Susan has, I have another question for you. Do you give your clients any nutritional information or cooking information in the case they're able to shop and prepare their own meals?
Yes, I have. I call it my third office. It's the trunk of my car. And I have a folder, a filing folder, and I have all sorts of information. I try and pull things beforehand if I have a chance to, get some information on the client and what their concerns are. But yes, and then in our area, we produce what's called a 55 plus book. It's a resource book, and many older adults, even though it's been published for many years, are not that aware of it, or maybe the family aren't aware of it. So I typically bring that also, so that they can go through it and see, well, what's available to me in my area.
Right. Yeah, and then we've got some responses from people, and I encourage others to, to tell us what you see as nutritional risk indicator. One of the people on the webinar says food that is moldy or overgrown in the refrigerator.
Yeah.
Another one says lack of fruits or vegetables. A limited amount of food, a lack of cooking supplies, lack of cleanliness, cluttered, significant weight loss, outdated food, canned without strength for use in can opener, and that is an issue. No signs of use of the kitchen, inappropriate dentures.
Right.
What types of food are in the refrigerator? Hoarding, gained too much weight. Let me see. Weight loss, reoccurring comments of being hungry, only having snacks, cookies, and candies and canned food to fill up the kitchen, the flavor of food and the taste buds, the mobility, if there are no stores or farmer markets close by. Lots of good comments. Thank you all for putting that in. Yeah.
Yeah, fantastic. And again, you're finding out this information by observation and conversation. You don't have to ask if your dentures fit well. Well, you probably do. But, there's certain questions you don't have to ask. It's pretty obvious on their food choices and what's in the kitchen. And it'll take you to the next step. So, and we'll talk about that in just a second. Those were wonderful responses. Great. I think, I have a list here. We can go to the next slide. But I think, a lot of it was brought up. So memory probably is one that didn't pop up, but social isolation. Anyway, yeah, great points. Thank you so very much.
Interesting remark about whether or not a person can handle frozen meals and whether or not they have choking or swallowing issues, food intolerances. So. Right.
So if you see just a lot of prepared meals, like the TV dinner type meals, then there's an indication of their cooking ability, and maybe it's physical, maybe it's mental, cognitive. Right. So it could be all sorts of different aspects. Okay, excellent, very good, thank you. All right, let's move on. Next slide, please. Now the bed and the bath, they're kind of adjuncts to the kitchen. And so it's good to take a peek. And again, you're looking for unsanitary conditions, soiled clothing, the safety and fall risk, maneuverability, toiletries, is there toothpaste in the bathroom, and just overall cleanliness. I think it reflects that person's ability to manage themselves in their home, and can lead you to looking for appropriate resources for those that are not able to do so. Okay, let's move to the next slide. Now I'm gonna change tack just a little bit because I want to introduce malnutrition assessment. There's a big push by A&D to train RDNs to do malnutrition assessments. There's a training going on all across the U.S. And I do it in my home visits. So it's not that you have to be in a clinic with a person in a gown, disrobed, that kind of thing. You can do it and get good information in a very comfortable setting. Okay, next slide, please. Okay, so what are we looking for? We're looking for energy intake. So there's that food access, all the things we've already been talking about, having family members give you input, the weight loss or weight gain within a certain time frame. Remember, we talked about the photos. There's a great way of judging weight gain and weight loss, or the ill-fitting clothes. And then there's physical findings. And this is more the nutrition-focused physical exam, and I'm going to talk about that a little bit more. But that's when we assess muscle mass and body fat and fluid accumulations. And then there's functional muscle strength. Those are simple to do too. Basically asking someone to stand up, or you can just observe them standing up out of their chair. You really want one that's more like a kitchen chair to see how well they can get up and move around, because that gives you lower body strength information. And then, as we were talking about indicators just a minute ago, looking for micronutrient deficiencies: hair, mouth, tongue, teeth, swallowing, taste, fractures, skin quality. There's so many of them, but you need to kind of tailor it to your population and decide which ones are that give you the highest yield. Okay, next slide, please. So back to that physical exam. Where do we look? So we're looking, and we're actually touching. So you need to introduce this to your client, letting them know that you're wanting to assess their body stores, as you might put it, and that, but again, there's no disrobing or anything like that. So we're looking at fat loss in the orbital region around the eyes, the triceps, the ribs, the muscle loss in the temporal wasting, looking at the clavicle, the deltoid, squaring of the deltoid. Then there's the interosseous muscle, which is on the hand. If you pretend that you're doing a hand puppet, that little muscle between your forefinger and your thumb just pops out, and that's the interosseous. But a malnourished patient would probably not have a significant amount as maybe you or I. Now, there's detail, and I'm going to encourage you to do the training, because over the phone on this webinar, it's a little hard to do. But my point here is that it's super easy, and it adds a great strength to your assessment. So besides the fat loss and the muscle loss, looking at edema in the ankles, the functional decline, we talked about the chair rise, that is getting up and out of the chair, and the other two points there, the hair quality and the mouth, etc. That's where we're looking, and there's certain nutrients that we'll be looking for, like the B vitamins, mouth and tongue, and the like, hair quality, the protein. Again, inviting you to go on A&D and find some of these, find some of their information, and then see who's training in your area. And don't be hesitant to do so. When I did mine, I had a dietitian on one side of me that was a burn unit dietitian. Whoa, that's pretty impressive. And on the other side of me, I had someone who's just as impressive, and that was the dietitian with our state aging and adult services. So we all come from different backgrounds, but it's all very applicable. Okay, next slide. Okay, then I'm just going to take you head to toe so you feel maybe a little more comfortable with this. So next slide. Okay, so as we already mentioned, again, here's the human body to look at. There's the upper body. You've got the temples, the orbital, the clavicle, the shoulders, the ribs, the arms, the hands. To tell you the truth, I don't do a lot of lower body strength testing in the home. It's a little more involved, and I can do just as good of an assessment with the chair rise, asking them to get up out of the chair on their own, and see how well they do. And that gives me a good idea of particularly their quad strength. So, that's the basics, and again, very, very doable. And I would encourage you to, again, take the training and then apply it in your setting. Okay, next slide. Okay, we've talked about a lot, and so now it's time to put together a plan of care. And so what you need to be doing is summarizing your findings, your observations, your conversations, make recommendations, and identify resources. And so I just wrote down a couple of an outline, potential outline, intake, looking, you've got the weight indicator and you've got the kitchen assessment of the food availability. Those work. Physical function, ADLs or IADLs, looking at current living situation deficits. The physical exam, which we've just talked about. I'll add in physical abuse. If there are signs of bruising, then that would be a point of conversation, gently. And then looking at social and psych, both the support systems, any memory deficits, and or financial emotional abuse. So you've got the different categories of your findings, and now it's time to, in your setting, to make the recommendations, and from those recommendations, identify potential resources that can assist, in addressing the deficits. So I have led you through a typical home visit process for me. Again, starting with the phone call, and making my way to the couch and having a nice conversation, and into the kitchen and looking at their food supply and cooking, etc. ability, and then moving into the physical exam. And to tell you the truth, this takes about 30 minutes. If you've got someone, older adults love to tell a story, and of course you need to entertain that. But it could make it to 40 if it's a long story and it's a really good one. But that's about the time limit, the time amount it takes me. So it's not like it's hours, and it's not taxing. And most older adults love the folks coming by to visit and to have a ability to tell someone about their health. All right. So I thank you, and I hope I've provided you with some information that can take you to the next step in developing some form of a home visit process. And at this point, I'll take questions or comments.
Yeah, absolutely, Susan, and thank you very much. There's quite a number of questions. I'll go through them as much as I can. One of our programs says they have their case manager doing the home assessments for every client they get, but how can they make a case for an additional home visit covering some but not all of the same issues and concerns?
So case management is screening. They can go in and they can look at, identify some risk, but they can't go to the next step. They can't connect. Their capabilities of connecting the dots is not as great as an RDN, because we can do that and then assess their nutritional status. So I always think about the intake. That initial visit is a screen. That is, have they identified weight loss? Well, then we have to get in and figure out why. And the why of it is why you need someone who has more training in the area of nutrition, because it takes a little more time to do that.
Mm-hmm. And then a question that kind of follows on this, and how do you fund your RDN home visits? It seems like you have a large volume of these visits in your organization or practice. Can you address that?
So there's a couple ways. One way is that, I'm in academia and we have educational dollars. So we have some money coming from that arena. But the other big push right now is our outpatient clinics are being tied to hospital admissions or readmissions. And so we have monthly meetings where we go through and assess. Well, we have a case manager, a care manager, who goes through and assesses different persons' health risk scores. Those folks at a high risk score come to the we review them in the meeting, and then if we can't figure out, how to best address the issues of that patient, then we go out and do a home visit, because that's going to give us the clarity that we need. Mm-hmm. So the hospital, our clinic systems, etc., are they're demanding this of us, that we need to sort this out. Now, maybe it's a medication issue solely, and so the pharmacist goes out, but rarely is it, again, one issue. They're overlapping, and so we work on them as a team. These meetings are interprofessional team meetings. So I assume other outpatient services are involved in the same process, and maybe that's a funding opportunity.
This is Holly. May I just say one thing? That we are talking about trying to break new ground. So we have the Older Americans Act programs, and those are running well, but we're trying to push the network a little bit further and use the resources they have, the nutrition professionals that are in the local provider level right now. But the executive directors and the dietitians at the local levels are going to have to brainstorm and figure out, how do we market this? What can we prove? How can we pilot it? So it is while the Medicare does pay for pre-renal and diabetes, you could become a Medicare provider that way, but there's a lot of ACOs and MCOs that have criteria that they get dinged if they have readmissions, rapid readmissions within 30 days. So the hospital dietitians are diagnosing malnutrition, but when they leave the hospital, what happens? I mean, they're in the hospital for a short time. It's the community that really can make a difference. And we need to have our voice heard and push a little further. So
I think the hospital route is a good one. I also see nationally that again, clinic systems are also looking at the same thing the hospitals are, and that's that readmission. And so there's a lot of doors that could be opened. And there's never enough dietitians within an outpatient setting, to deal with the numbers of cases of malnutrition that need working up. And so joining forces is definitely an option.
And may I also say, I'm sorry, Magda, I'm trying to incorporate some of these questions, but Sherry Simon offered from Tarrant County, she is meeting with ACOs. She's the one that brought on 6 dietitians, and now they do routine home visits, and they coordinate with their local hospitals because they have proven that their nutritional assessment makes a difference in healthcare costs or keeping healthcare costs down. If your agency isn't doing this, then think about, is there a need? Is your local community flush with community-based dietitians that the market's already flooded? I'm kind of joking a little bit because I highly doubt that. And your dietitians in the Older Americans Act programming, they know older people, and home and community-based programs are pushing care into the home. This is an opportunity for the dietitians to become the leader. And Susan is offering some suggestions, but there is no easy path to getting this done.
There's one other program that's really taking off. It's called Hospital to Home, and it's actually it was a UK program, but the US many centers are adopting it. But the idea is that they're wanting to move the patient out of the hospital even faster than they already do, and accommodate them in the home. And so they're going home malnourished commonly. And when I've talked to some of the nurse managers of these programs and the like, and I just say malnutrition, they go, "Oh my gosh, yes, a huge issue. We're trying to address it." And so I think staying on the developments within the health care, the health services systems might open some doors that way too.
Right. One other question for you, Susan. You talked about the importance of home visits and home assessments, etc. But once you've done that, can you also do those kinds of assessments in other settings? Thinking about, for instance, a church or a congregate center or something like that. So in addition to.
Yeah. Again, the wealth of information is inside the home, and so that's that's the gold mine. But if doing the assessments in other settings, surely, you don't have to be in a clinic setting. Yeah, there's other opportunities. I'm having a little trouble envisioning exactly how that would work, but then that's what you guys are all about. You know your systems better than I do.
Right. Well, I think in the interest of time, I want to thank you very much, Susan and Holly, for offering this webinar. Holly, your comments are very much appreciated. Susan, you had a lot of good information to share with the people on the webinar. Again, to everybody, we'll send around the PowerPoint tomorrow with a link to the recording and a link to a PDF of the PowerPoint. When you log out, please take a moment to fill out the evaluation. We always read the comments that you make and try to incorporate those comments into future training. So do take, it's a minute, 2 minutes to fill out the evaluation. Thank you all for participating. Thanks to Holly and Susan for presenting. Have a wonderful afternoon and see you on the next webinar. Bye.